In this video, we'll review our control of eye movements. In part, we control our eyes consciously. We can choose what we look at, and we do so with fast ballistic movements called saccades. We also have a variety of non-conscious eye movements that help hold our gaze on whatever it is we've chosen to look at. So when we choose to look at something, we quickly move our eyes toward it, and then we carry out slow, smooth, reflexive movements to keep our eyes fixed. These movements can be elicited with the vestibulo-ocular reflex, so if our head moves, our eyes move accordingly to keep gaze fixed. We can also elicit smooth movements when we track an object. Although I can't move my eyes smoothly from left to right, I can if I look at my finger. So in this case, I've chosen to look at my finger. When my finger moves, instead of my head moving, I elicit essentially a VOR, but I use the cortex to trick the vestibular nuclei. In the first part of this talk, we'll go through all of the motor control of the eyes, and this is the bulk of the talk. The second part, we will review the autonomic innervation of the eyes through the third cranial nerve, as well as sympathetic input from the thoracic spine. This movie that's playing is showing you smooth pursuit, but because of damage to the cerebellum, we see these saccades creeping in. The smooth pursuit's not quite fast enough, and we have catch-up saccades in order to keep the eyes fixed on the target. Control of the eyes is carried out by cranial nerves 3, 4, and 6. The bulk of the innervation comes from cranial nerve 3. Cranial nerve 6 controls the lateral rectus on the same side, so we abduct the eye, so it turns the right eye right and the left eye left. The trochlear nerve supplies the contralateral superior oblique. The superior oblique is involved with depression of the eye, so looking down, as well as intorsion of the eye, so rotational movements toward midline. Whether we get depression or intorsion depends on the angle of the eye. We'll see that in just a bit. The oculomotor nerve is the major nerve of the eye. This allows us to keep our eyelids open. So with profound damage to cranial nerve 3, the eyelid remains closed. Cranial nerve 3 also innervates the remaining 4 extraocular muscles, so the ipsilateral inferior rectus, inferior oblique, and medial rectus. There's also innervation of the contralateral superior rectus. So as you can see here, the 2 superior muscles get contralateral innervation from their cranial nerves. The oculomotor nerve also supplies the parasympathetic innervation for the eyes, which we will touch on in the next part. Okay, those eye movements are controlled by 6 muscles. 2 of them are pretty darn simple. Medial rectus always brings the eye toward midline. Lateral rectus always takes the eye away from midline. But the other muscles hit the eye at angles, imperfect angles. So when our eye is facing forward, as you can see, if you look at the illustration over here, the superior rectus hits the top of the eye at a bit of an angle there. You can see, 23 degrees or so off center. So when I pull on the eye, if I'm facing forward, this will cause some elevation. but it's also going to cause a rotation inward. So the eye will go up. If we consider my left eye, it'll be brought upward, but it'll also be rotated where the top goes toward the nose. That's called intorsion. So I need to have a balance of activity in my superior rectus and my inferior oblique, both of which give me elevation, but one gives intorsion, the other gives extorsion. If I move my eye, let's say this is my left eye here, if I move it toward midline, so if I look to the right, if I'm adducted, then the superior rectus here is only going to cause a rotation of the eye. Notice the angle here. On the other hand, if I were to look left, so if I were to abduct my eye, now my line of vision is in line with the superior rectus, and so contraction here is going to give elevation of the eye. This is all summarized in the table below there. Now, the oblique muscles come at a completely different angle. They're going to hit about 90 degrees to the rectus muscle, and they wrap around a little piece of cartilage there, the trochlea. So contraction of the superior oblique is going to cause rotation of the eye if I'm abducted. This is my superior oblique, superior rectus. Now let's go back to adduction. If I'm looking toward midline here, so rotate the left eye toward midline, now I'm looking this way, contraction of the superior oblique is going to pull the top down, giving me depression. So up and down movements of the eye are going to involve a combination of rectus and oblique muscles. Superior rectus and inferior oblique working together for elevation. Superior oblique and inferior rectus working together for depression. We just have to balance the amount of activity so that we don't get any torsion of the eyes. And that relative balance depends on eye position. If I'm completely adducted, then the superior oblique is just going to give me depression. If I want depression while abducted, I need the inferior rectus. In each of these eye muscles, there are two muscle types. There's your typical fast twitch fibers. These fire action potentials. And they also have their neuromuscular junctions at specific sites. Here we can see on the left, that recording is showing you an action potential in fast twitch fibers. These are useful for creating saccades. The non-twitch fibers, you can see on the on the right, part B there, no matter how much depolarization they give, no action potential propagates throughout the muscle. So you get focal areas of contraction giving you much smoother and fine adjustments of muscle length. So fast twitch, very useful for saccades, and the non-twitch, useful for smooth pursuit and gaze fixation. The pattern of synapses varies. So for fast twitch, those that fire an action potential, we see focal innervation and plaque, in other words. So just one big area of innervation. This is also called singly innervated fibers. This is just a motor neuron coming off here. Because these muscle fibers fire action potentials, depolarization here spreads through propagation of the muscle action potential. So a single site of innervation will work. and I'll get rapid contraction along the entire length, thus a much larger eye movement. The non-twitch fibers have what we call multiple innervation, in grape, kind of like grapes on a vine. So innervation along multiple sites. These are also called multiply innervated fibers. We only get depolarization at the sites of the neuromuscular junction, and that depolarization spreads passively. So rather than the entire muscle contracting, as in our singly innervated fiber, here we'll get local contractions, so much finer adjustments. At the ends of non-twitch fibers, we have palisade endings, and these also allow for adjustment of the muscle length. They appear to be both sensory and motor in structure. We believe that they're motor in structure because they have nicotinic acetylcholine receptors at them. So here we're looking at palisade endings. The green signal is showing us alpha-bungarotoxin. Alpha-bungarotoxin shows where nicotinic acetylcholine receptors are located. Alpha-bungarotoxin is just a snake venom used to paralyze its prey by binding to nicotinic acetylcholine receptors. So at the ends, we also adjust. So we have our in-grop synapses here, and then at the ends, we have palisade endings. Both of these are going to allow for fine adjustments. Here, got an extra L there. Fine adjustments of these non-twitch fibers. And I believe these are the only consciously, these are the only muscles, striated muscle, that don't fire action potentials. Let's start off with conscious eye movements, breaking our gaze to something new. I can look at the camera, I can look over there at the wall, right? I get these fast movements to find whatever it is I'm looking for, and then once I find it, I'll hold it there. Holding is non-conscious. The breaking of the gaze, those are the saccades. These are fast ballistic movements that are created by gaze centers. There are two gaze centers, the paramedian pontine reticular formation, it's in the pons, near the reticular formation. And then there's the rostral interstitial nucleus of the medial longitudinal fasciculus. Heck of a name, it is a mouthful. Some people also call it the thalamo-mesencephalic junction, or the TMJ. Fair enough. The paramedian pontine reticular formation has both a left and right component, so that creates left and right saccades. The rostral interstitial nucleus of the medial longitudinal fasciculus, again, has two components. There's a dorsal and ventral. Dorsal for up gaze, ventral for down gaze. So this is kind of like a directional pad on a controller. You can move up, down, left, or right, depending on which gaze center you activate. Within the gaze centers, we have different types of neurons that are going to accomplish different tasks. We have tonic neurons, as the name says. They provide a relatively constant amount of motor output. That's to keep muscle tone in the extraocular muscles relatively constant, so we can hold our eyes still. When we create saccades, we turn off omnipause neurons. These are local inhibitory neurons that prevent burst neurons from firing. When we turn off omnipause, burst neurons fire. As the name suggests, they fire a high frequency of action potentials, a burst, onto extraocular muscles, causing quick increases in muscle tone. So we get fast movements. Then there are also inhibitory neurons connecting the different gaze centers, left, right, up, down. So you only look left, not right. You can't do both at the same time. You can indeed converge the eyes, but that's not through gaze centers. That goes outside of there. Those are not saccades. That's just a vergence movement. So in each gaze center, we're going to innervate the lower motor neurons that control extraocular muscles. So for left gaze, I want my left abducens and my right oculomotor nucleus. The tonic neurons provide relatively constant input. Burst neurons are silent until we want a saccade, then they burst fire, and then they're silent. The reason they're silent is because omnipause neurons hold them in a state of inhibition. They're named omnipause because we will see many pauses as we move our eyes. Each pause here corresponds with the burst from the burst neurons. Tonic create tone, burst creates that saccade, and omnipause suppresses the saccade. Let's have a look at the basic circuitry here. Here we can see a slightly more elaborate version of the gaze centers. Here they're showing you the paramedian pontine reticular formation. In this case, we're getting left gaze because the left side is more active. So what's going on here would be that left-right coordination. So we've got inhibitory interneurons that'll cross over, make sure the tonic and burst neurons over here are inhibited. So they're not talking to the right side. The only side that's active is the left. If we stimulate the abducens, so if we sum these together, what it looks like is we hold some kind of tone, we get a burst for a fast movement, and then we continue to hold tone. Lower motor neurons go to the lateral rectus. There are interneurons in that medial longitudinal fasciculus that create the internuclear tracts. So cranial nerve 6 activates cranial nerve 3, going to the medial rectus on the right. And in both cases we get a fast ballistic movement, and then we hold our tone. The control of saccades, of course, begins in the cortex. We've made a decision to look at a particular object. This starts in the frontal eye fields based on input from the supplementary eye field and the parietal cortex. As we'll talk about later, the parietal lobes is where we have our map of the world. So based on where the object is in the world and where our eyes are located, the frontal eye field determines where we should move our eyes in order to bring our gaze onto the object of interest. The frontal eye fields stimulate the superior colliculus. The superior colliculus then stimulates the gaze centers. We'll see a summary of this in just a little bit. The other target of the frontal eye fields is the caudate nucleus. So we're going to go into the basal ganglia and inhibit the substantia nigra. The substantia nigra normally inhibits saccades. So we turn off the substantia nigra, we don't inhibit saccades, so they happen. The frontal eye fields have contralateral innervation. Let's have a look here. So ipsilateral for the superior colliculus. In this case, we're starting at the bottom. So the illustration on the left is where we have no particular imbalance in our frontal eye fields. We haven't initiated a saccade, in other words. We're just looking straight ahead. Here, the central mesencephalic reticular formation keeps omnipause neurons active, so we're not bursting. All we're doing is maintaining a little bit of tonic output to the abducens. The abducens then stimulates the contralateral oculomotor nucleus, and we're holding our gaze straight ahead. On the right, let's say we want to look to the right. Okay, the left frontal eye fields create right saccades. So the left frontal eye field stimulates the left superior colliculus. Collectively, these two then inhibit the central mesencephalic reticular formation. So we no longer activate omnipause neurons. Here we get our pause for omnipause. At the same time, we're also stimulating the contralateral paramedian pontine reticular formation. That is the right paramedian pontine reticular formation. So frontal eye fields and superior colliculus cross over, stimulating tonic and burst neurons, as well as those commissural inhibitory interneurons. Stimulating the tonic neurons increases muscle tone. So our eyes are going to move to the right. And they will move to the right very quickly because we also stimulate burst neurons. We do this with excitation and disinhibition. So turn on the burst neuron and turn off the omnipause neuron. That burst creates the saccade, and that increase in tone holds our eye there. Inhibition of the left paramedian pontine reticular formation, of course, reduces muscle tone in the right medial rectus and the left lateral rectus, so our eyes don't turn left. And that's a saccade. If we want to turn left, the right eye fields stimulate the left paramedian pontine reticular formation. So just flip that circuit diagram around. Smooth pursuit is not contralateral. This is instead ipsilateral. Frontal eye fields will help hold our gaze on the target of interest by communicating with the temporoparietal occipital cortex. This is where pursuit movements are generated. So, the temporoparietal occipital cortex has a variety of inputs. It knows our eye position, it knows the position of our object, it has an idea of what movements the frontal eye field is going to carry out, and the frontal eye field helps guide its movements. But we decide what we want to look at, and we hold our gaze there. Anytime our visual field no longer has the object of interest in the center, we get the corrective eye movement to restore it. So if I want to look at my laser pointer here, it moves to the right. I'll get a right smooth movement to hold it in the center of my visual field. So this reflex, like most other reflexes, is there to correct an error. So we start off in the temporoparietal occipital cortex. From here, rather than projecting to the superior colliculus, we project to the dorsolateral pontine nuclei. From there we cross over, here's our first cross, going into the cerebellum. We go to the flocculus. That of course communicates with the vestibular nuclei as its deep cerebellar nucleus. The vestibular nuclei cross over again to hit the contralateral abducens, so the same-sided abducens, in other words. Right, this is a double cross. So my left TPO goes to the left pons, right cerebellum, left abducens, so my left eye will turn left, and we'll do a good old triple cross to hit that oculomotor nucleus so that my eyes move together. We have bypassed the gaze centers. We're not initiating a saccade. In this case, The input comes from the 8th cranial nerve. So the left TPO goes to the left pons. We've gone over into the flocculus. We crossed over, so we're in the cerebellum here, stimulating the right vestibular nucleus. This gives us the impression that our head is moving to the right. It is not. But because we think our head is moving to the right, we get a left VOR. And it's smooth. We're not recruiting burst. No burst neurons, no saccade. Instead, we get smooth eye movements. So that left smooth pursuit that I just initiated, left TPO, right cerebellum, right vestibular nucleus, left abducens, right ocular motor. Triple cross. So this is essentially the VOR, but it starts in the cortex because of not head movement, object movement. So it's a little bit slower than the VOR. You'll see a longer latency because the VOR doesn't require any of this cortical calculation. It's just, did my head move? Did the semicircular canal sense head rotation? If so, we go directly to the vestibular nuclei. In order to get here, I had to start in the cortex. I had to go down to the pons. I had to cross over here. This TPO, of course, had multiple bits of information to think about. Where are my eyes? Where's the object? What's going on? Then we got a few synapses. No. Primary afferents going to secondary afferents for the VOR. Turn your head to the right. That's what's going on in this diagram over here. Stimulate the right side, inhibit the left. Clearly my head is moving to the right. The right vestibular nucleus, when it's active, turns on the left abducens, which turns on the right oculomotor. So the left eye goes left and the right eye goes left. Good old double cross, but fairly simple. Primary afferent, secondary afferent, and then we're in our ocular nuclei. Damage along these areas that we've outlined here and in the previous slides create problems with eye movements. If we have damage in the frontal eye fields, for example, or the superior colliculus, those areas involved with saccades, we either have slower saccades or we are unable to initiate them, depending on how severe the damage is. Damage to gaze centers impairs our ability to carry out voluntary eye movements, but we can still have smooth pursuit, things like that. Damage to the lower motor neurons in the cranial nerve nuclei, 3, 4, and 6, obviously creates weakness and paralysis of the eyes. Damage to the vestibular system, whether it be the primary or secondary afferents here, will impair the vestibulo-ocular reflex and smooth pursuit. Damage in the basal ganglia will affect our ability to suppress saccades. So if we have neurodegeneration in the basal ganglia, such as in Parkinson's disease, where there's profound neurodegeneration in the substantia nigra, we see involuntary saccades during smooth pursuit. You can see those over here in those data. So control is just showing you the eyes moving left and right, nice and smooth, kind of a sinusoidal wave there. On top, the recordings from a patient with Parkinson's disease shows you the smooth pursuit works fairly well, but you get these breaks, these involuntary fast eye movements. So they weren't able to completely suppress saccades. So we're looking left, as we're looking right, boom, right saccade, look left, we get a few involuntary saccades. It's not just a left, right, right. Damage in the cerebellum affects both saccades and smooth pursuit. Again, we want to think about dysmetria and dysrhythmia. wrong distance, wrong timing. Saccades are slow. Look in part B there. Saccades, we're not getting these nice sine waves, we're getting square waves. We should have fast ballistic movements. Well, why don't I erase? When an object moves, our eyes should quickly follow along with very little delay. What we see after they're given the cue to move, there's this delay in part B there. These don't match up. Their actual eye movements don't occur when they should. So slowed saccades. And also the smooth pursuit, shown in part A, you can see is kind of herky-jerky. They're not able to time their movements correctly. They'll have to have some catch-up saccades. There are involuntary saccades occurring, and it's not smooth by any means. It's, rather than a wave, it's a collection, it's more of a stair step. So little tiny flickers. Those changes occurred because of damage in the medial aspect of the cerebellum. So you can see there's an infarct in the medial branch of the superior cerebellar artery. In addition to controlling eye muscles, we also have to control some smooth muscles in the eye. That will change the amount of light that we allow in and where we focus the light. Okay, the pupillary light reflex is very commonly tested, and this involves cranial nerves 2 and 3. Cranial nerve 2 detects the light, cranial nerve 3 responds to the light. So when we shine light on the pupil, we're getting an increase in brightness. Reflexes are there to cancel out changes, so we want to find some way of decreasing brightness here. Alright, so we'll come together, there's an optic chiasm, and then the tracks will come back. And we're going to hit, in this case, the tectum. These will continue back into the lateral geniculate nucleus for vision, but that's not what we care about. We're going to stop off in the midbrain. I need a midbrain back here. Yeah, close enough. So retinal ganglion cells, depending on where they're located, they'll project to different parts. It doesn't really matter. Everything's going to be bilateral. So some retinal ganglion cells directly sense light. Those that do project into the pretectal nuclei. So primary, here's my secondary, up there in the pretectal nucleus. And from here, we then project to the third cranial nerve. A more medial portion of it called the Edinger-Westphal nucleus. And this is bilateral. So it doesn't matter which eye we shine the light into, both are going to respond. So the pretectal nucleus, those are just interneurons. The parasympathetic neurons are in the Edinger-Westphal nucleus. These project out along the third cranial nerve, innervating the ciliary ganglion. Postganglionic. Edinger-Westphal, preganglionic. From here we provide parasympathetic innervation onto the iris there. So we're going to hit the sphincter pupillae, acting on M3 muscarinic receptors. M3, because it's odd, is GQ coupled. GQ is going to cause excitation of smooth muscle. So the smooth muscle constrict. This is a sphincter, so it decreases in size as a result. So we constrict the pupils, and that decreases brightness. So when there's an increase in light on the retina, we decrease the amount of light. If there's a drop, retinal ganglion cells aren't as active, pretectal nuclei is not as active, Edinger-Westphal not as active, less input to the ciliary ganglion, less input to the iris, and so we dilate our pupils. So if there's a drop in light, we increase. If there's an increase in light, we decrease it. This works fairly well. It doesn't work so well for extreme changes, like if you're in a movie theater and then you go outside. Your pupillary light response is not going to fix that. You have to wait for your retina to bleach a little bit. Then the light doesn't hurt as much. The oculomotor nerve also is responsible for the accommodation reflex. In the accommodation reflex, when we look at objects that are closer, so when we have vergence of the eyes, when our two eyes converge, so when you cross your eyes, this triggers a reflex where we have a thickening of the lens and constriction of the pupils. Again, Edinger-Westphal nucleus is responsible here. The input, though, does not come from the retina. It comes from the reticular formation. So neurons that are going to bypass our gaze centers, vestibular nucleus, they project directly to the third cranial nerve and allow us to bring our eyes together. When the eyes come together and we stimulate the Edinger-Westphal nucleus, we will still get constriction of the pupils. There's additional targets though, and that would be the ciliary muscles. These are smooth muscles that hold the lens, as you can see over there, suspended by these little ligaments. When we contract the ciliary muscles, they become fatter, decreasing tension on the ligaments and allowing the lens to widen. Again, we're dealing with M3 GQ coupled muscarinic receptors. So on top you can see that eyeball has a much fatter lens because of parasympathetic input. Sympathetic input, on the other hand, uses beta adrenergic receptors, which are GS coupled. This relaxes the ciliary muscles, so they are not as fat. They lie closer to the edge of the eye there, and thus they increase tension on those ligaments and flatten the lens. Sympathetic input does not come from a cranial nerve, of course. This comes from the spinal cord. This is a fairly roundabout way of getting there. So the dorsal longitudinal fasciculus from the hypothalamus to the thoracic spine stimulates sympathetic output. From the thoracic spine we go to the superior cervical ganglion. From there we follow along the carotid arteries as the ciliary nerve and innervate the eye. There are a few targets. First of all, we flatten the lens, like we just saw, so we'll innervate ciliary muscles. Beta adrenergic receptors are GS coupled, and thus they cause relaxation. We also raise the eyelids further. Mueller's muscle is innervated by alpha 1 adrenergic receptors, which are GQ coupled. We also control the pupil, and we hit an additional target. Not only do we hit the sphincter pupillae, just like the parasympathetic division, we also hit the dilator pupillae. So the sphincter, when it contracts, decreases the size of the pupil. Contraction here creates a much smaller pupil, and relaxation creates a larger pupil. adrenergic receptors cause relaxation of the sphincter, while the M3 muscarinic receptors cause constriction, and thus constriction of the pupil. There's an additional input outside of this, the dilator. These muscles are not organized circularly. Instead, they're arranged radially. So when these muscles contract, they're going to pull the center outward, thus causing dilation. So we'll again dilate, but in this case, because of contraction of the dilator pupillae rather than the sphincter. The dilator is stimulated by alpha-1 adrenergic receptors, which are GQ. And that about does it for our eyes. If there's anything that isn't clear, please enter it in the questions box so I'll know what to talk about in class. See you later.